Good afternoon, ladies and gentlemen, dear colleagues and members of the panel. Esteemed Chairman, thank you very much for the opportunity to report our results in such a prestigious meeting. There are many theoretical advantages correlated to the lower length of surgical incision and intact sternal bone, improved postoperative respiratory function, reduced postoperative pain and recovery, better cosmetic results, reduced surgical trauma and blood loss, facilitated reoperation, more rapid return to normal activity, and less utilization of rehabilitation resources. It provides as well beneficial effects in elderly patients, and last but not least, less impact on financial resources. Minimally invasive aortic valve surgery has evolved into a well-tolerated, efficient surgical treatment option in experienced centers, providing greater patient satisfaction and lower complication rates. Every other potential advantage listed above was demonstrated in practice, though not necessarily by randomized controlled trials, and that's why minimally invasive aortic valve replacement is increasingly being performed and has become an alternative to standard stenotomy. Some studies showed potential advantage in blood transfusion, earlier extubation, and hospital discharge. Others failed to prove the theoretical advantages of minimally invasive aortic valve surgery. Meta-analysis of RCTs showed no difference in early mortality, cross-clamp time, ventilation time, ICU and hospital stay, incidence of atrial fibrillation, postoperative pain, and sternal complications. But we should remember that most of the studies on minimally invasive aortic valve replacement were focused on mini stenotomy. We desire to compare short-term clinical outcomes between minimally invasive and conventional stenotomy groups. Through January 2004 and March 2011, detailed clinical information on 709 patients was entered in database, and propensity score matching analysis was performed on 182 pairs of matched patients. Peculiarity of the present study is that the same surgical team in the same period of time applied two different minimally invasive approaches for aortic valve replacement, which subsequently were compared together with the standard stenotomy. All patients in preoperative period were studied by CT scan without contrast enhancement for the surgical approach decision. Favorable anatomical disposition for mini thoracotomy is confirmed when aorta is rightward. More than 50% of ascending aorta lies out of the right margin of the sternal at the level of pulmonary trunk bifurcation and is not hidden behind the sternum. While the distance from ascending aorta to sternum is not more than 10 centimeters. Another anatomical condition, though not important so much, is that the angle between middle axis of ascending aorta and the sagittal plane, which should be 45 degrees or more. Central arterial cannulation, femoral venous cannulation with Seldinger technique, and antegrade cardioplegia are usually performed. CO2 is inflated inside the pericardial cavity before the decannulation. And you see the intraoperative setting of the patient during minimally invasive aortic valve surgery. Compared with the conventional AVR group, patients who had minimally invasive AVR surgery were younger, taller, had slightly higher body mass, but lower body mass index, had a lower prevalence of female patients, and patients with low left ventricle ejection fraction, obesity, arterial hypertension, and COPD. In the matched cohorts, there was no longer any significant difference between the two groups for any covariate. In the matched 6 cases, 3.3% with conversion to stenotomy in minimally invasive group were analyzed is intention to treat. Both cardiopulmonary bypass time and the aortic cross-clamp time were longer in minimally invasive group. Overall, in-hospital mortality was identical between the groups. Assisted ventilation time was lower in minimally invasive group, as well as the incidence of new onset of atrial fibrillation and blood transfusion, as you see in this slide. 40 and 84% risk reduction for postoperative atrial fibrillation and transfusion risk was observed, respectively. The multivariable regression analysis revealed that the duration of cardiopulmonary bypass over 110 minutes was an independent risk factor for in-hospital mortality. Another independent predictor of mortality was operative priority. Limitations of the present study include retrospective design, short follow-up time, low number of fatal events, and initial phase of our experience with learning curve effect. To conclude, minimally invasive, isolated aortic valve surgery through mini thoracotomy or mini stenotomy is a reproducible procedure as effective and safe as AVR via stenotomy and reduces assisted ventilation duration, the need for blood product transfusion, and incidence of post-surgery atrial fibrillation. Thank you very much for your attention, and I would like to thank organizative committee for the privilege of the podium. Thank you very much.